Hello friends, myself Professor Khyati Gupta, working at Dr. Subhash Technical Campus, Faculty of Pharmacy, Junagadh. Today in this video lecture, we will see about local anesthetic agents. Local anesthetics are the drugs which upon topical application or local injection cause reversible loss of sensory perception, especially of pain in a restricted area of the body, right? So these are the drugs that can be used before minor surgery because these drugs cause reversible loss of sensory perception and especially of pain. Further, these drugs block generation and conduction of nerve impulse at any part of the neuron with which they come in contact without causing any structural damage. So, the advantage of these drugs is they can't do any structural damage, right? Next is classification of local anesthetic agents. They are classified into two types. First is injectable local anesthetic agents and second is surface local anesthetic agents. Here, injectable local anesthetic agents are further classified into three parts: lower potency and short duration of action, intermediate potency and intermediate duration of action, and high potency and high duration of action. Next, surface local anesthetic agents are classified further into two types: insoluble surface local anesthetic agent and soluble surface local anesthetic agent. Next is mechanism of action of local anesthetic agent, right? Now, in this figure, you can see three three sub figures, right? In that first figure is of resting position, second figure is of activated position, and third figure is of inactivated position. Here you can see sodium channel in these three figures. First figure, here M means mouth, or you can see entrance of sodium channel, right? And H means halt gate, right? Means exit of sodium channel. Here you can see yellow colored dot, it is a local anesthetic receptor, right? Now when resting state is there, M, or you can say mouth of this sodium channel is closed, right? But when polarization occurs or stimulation occurs, right? Mouth of this sodium channel opens. It indicates activation of sodium channel. You can see in second figure that sodium ion can passes through that sodium channel through mouth and halt gate of sodium channel. But this position is only for milliseconds. After few milliseconds, inactivation situation occurs. In that, mouth of sodium channel is open, but its exit is closed, right? Halt gate is closed. Therefore, sodium flow ceases into the channel and more sodium ions cannot pass through this channel. Understood, right? This is the mechanism of action of local anesthetic agent. When local anesthetic agent binds to local anesthetic receptor, it closes the halt gate, right? Or closes the exit. So here the sodium channel has an activation gate or MAG or M gate. You can also tell it to mouth of this sodium channel near its extracellular mouth and an inactivation gate at intracellular mouth, right? In the resting state, the activation gate is closed. Threshold depolarization of membrane open, the activation gate allowing sodium ions into the flow in along the concentration gradient. But within a few milliseconds, the inactivation gate closes and ion flow ceases. The channel recovers to the resting state in a time-dependent manner, right? This is the mechanism of action of local anesthetic agent. Binding of local anesthetic agent to its receptor stabilizes the channel in the inactivated state and thus reduces the probability of channel opening. Okay. Next is physiological actions of local anesthetic agents. First, on the central nervous system, it acts. All local anesthetic agents are capable of producing a sequence of stimulation that is followed by depression, right? Like cocaine, which is a local anesthetic agent. It is a powerful CNS stimulant. So first, there are stimulated situations like euphoria, excitement, mental confusion, restlessness, tremor, twitching of muscles, convulsions, etc. Right? And these situations are followed by depressive situations like unconsciousness, respiratory depression, and death. Right? But these all actions are in a dose dependent manner. Okay. Second, actions on cardiovascular system. In that first, on heart, local anesthetic agents are cardiac depressants. This cardiac depressive action is not at regular or conventional doses, but at higher doses they are cardiac depressants. They have a quinidine-like antiarrhythmic action. Procaine is not used as antiarrhythmic because of short duration of action and propensity of producing CNS effects. But its amide derivative like procainamide is a class 1A antiarrhythmic drug, right? Now on blood vessels, local anesthetic agents tend to produce fall in BP, right? This is primarily due to sympathetic blockage, but at high concentration as obtained locally at the site of injection do cause direct relaxation of arterial smooth muscle. Okay, so because of vasodilation, local anesthetic agents decrease blood pressure. Okay, bupivacaine is more vasodilatory than lidocaine, while prilocaine is the least vasodilatory agent. Toxic doses of local anesthetic agents produce cardiovascular collapse. Next is pharmacokinetics. Soluble surface anesthetics like lidocaine and tetracaine are rapidly absorbed from mucous membranes and abraded areas, but absorption from intact skin is minimal. Okay. Procaine does not significantly penetrate mucous membranes. Rate of absorption depends on the blood flow to the area of application or injection. The absorbed local anesthetic, being lipophilic, is widely distributed, rapidly enters highly perfused brain, heart, liver and kidney, followed by muscle and other viscera. Procaine is negligibly bound to plasma proteins, but amide local anesthetics are bound to plasma alpha-1 acid. Okay. Local anesthetics are rapidly but temporarily bound to tissues, especially nerves at the site of injection. Ester-linked local anesthetic agents are rapidly hydrolyzed by plasma pseudocholinesterase and other remaining by esterases in the liver. Okay, as you know, drug metabolism, right? So, in drug metabolism phase 1 reactions, we have seen hydrolysis, right? So the drugs that contains ester functional group that are hydrolyzed and that way they metabolize, right? So here local anesthetics which containing ester as a functional group, they are hydrolyzed by plasma pseudocholinesterase enzyme and the remaining by esterase enzyme in the liver, as the liver is the major site for drug metabolism. Amide-linked local anesthetics are degraded only in the liver microsomes by dealkylation and hydrolysis. Metabolism of lidocaine is hepatic blood flow dependent, right? As you know that liver is a major site of drug metabolism. As the hepatic blood flow will higher, the drug that reaches to liver, that drug concentration will be higher, right? And drug metabolism will be higher. Okay, so metabolism of lidocaine is hepatic blood flow dependent. The maximal safe dose of local anesthetic is lower in patient with hepatic disease and elderly who have decreased liver function. Okay, so the patients that have decreased liver function, they have maximal safe dose of local anesthetic, it will be lower. Okay, After oral ingestion, both procaine and lidocaine have high first pass metabolism in the liver. Thus, they are not active orally for antiarrhythmic purposes. Okay, next is adverse effects. As we have seen that local anesthetics have physiological actions on CNS and CVS, right? So definitely they have some adverse effects on CNS and CVS, right? So here CNS effects are lightheadedness, dizziness, auditory and visual disturbances, mental confusion, disorientation, shivering, twitchings, involuntary movements, finally convulsions and respiratory arrest. This can be prevented and treated by diazepam. Cardiovascular toxicity of local anesthetic is manifested as bradycardia, hypotension, cardiac arrhythmias and vascular collapse. So, it is the cardiovascular toxicity. Injection of local anesthetic may be painful, but local tissue toxicity of local anesthetic is low. However, wound healing may be sometimes delayed, right? And lastly, precautions and interactions. Before injecting the local anesthetics, aspirate lightly to avoid intravascular injection. Second is inject the local anesthetic slowly and take care not to exceed the maximum safe dose, especially in children. Third is propranolol may reduce metabolism of lidocaine and other amide local anesthetics by reducing hepatic blood flow. Therefore, propranolol cannot be given with local anesthetic agents. And fourth is vasoconstrictor containing local anesthetic should be avoided in patient with ischemic heart disease, cardiac arrhythmia, thyrotoxicosis, uncontrolled hypertension, and those receiving beta blockers or tricyclic antidepressants, right? Because vasoconstriction is the adverse effect of local anesthetic, and if you give a vasoconstrictor with local anesthetic, the vasoconstriction will be increased. So these combinations cannot be given. Okay, so this is all about local anesthetic agents. Thank you, friends.